Hello, let's learn our what are the reasons to optimize antibiotic resistance is a result of antibiotic overuse. The resistance impacts clinical outcomes and therefore it is a serious patient issue. Bacterial resistance impacts medical resources because most hospital acquired infections are caused by drug resistance bacteria. This is the wordings that I will quote from Sir Alexander Fleming. Words to hear from decade past. This includes the public will demand the drug and they will begin an era of abuses. The microbes are educated to resist penicillin, and a host of penicillin-passed organisms is bred out, which can be passed to other individuals and perhaps from there to others until reaches someone who gets a septicemia or pneumonia, which penicillin cannot save. In such a case, the thoughtless persons playing with penicillin treatment is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. I hope the evil can be averted. Rightly said by the Sir. What are the reasons to optimize antibiotic use? Selections. First is selection of changes in the antimicrobial use are paralleled by changes in the prevalence of resistance. Resistance is more common in healthcare-associated infections compared with community acquired. When compared with controls, patients harboring resistant organisms are more likely to have received prior antimicrobials. Areas within hospitals that have the greatest rate of antimicrobial resistance also have the greatest rate of antimicrobial utilization. Increase the duration of patient exposure to antimicrobials increases the likelihood of colonization with resistant organisms. What are the current causes of majority of US hospital infections which effectively escape the effects of antibacterial drugs? This include Enterococcus faecium, Staph aureus, Klebsiella pneumonia producing E. coli and Klebsiella species, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter species, abbreviated as ESCAPE. This six group of bacteria currently cause the majority of the hospital infections and effectively escape the effects of antibiotics. Some strains have become resistant to all the antibiotics. Therapeutic options are so extremely limited that clinicians are forced to use the older ones such as colistin. Emergence of resistance can be rapid and alarming. The case of carbapenem resistant to Klebsiella pneumonia is alarming. It was first described in 1999 and an analysis of 2007 data showed that 8% of Klebsiella are carbapenem resistance. The rise in the ESBL producing Klebsiella pneumonia was observed in a 500-bedded hospital, and compared with the ESBL detection and the colonization rates, imipenem was used for the treatment of ESBL producing Klebsiella pneumonia. The results of cephalosporin restriction caused 80% reduction in the hospital-wide use of cephalosporin, 141% increase in the imipenem use, 40% reduction in the incidence of cetirizine-resistant Klebsiella pneumonia overall, 70% reduction within all ICUs. At the end of the restriction period, concomitant 70% increase in the incidence of imipenem resistance to Pseudomonas aeruginosa occurred throughout the medical system. When you divide every 15 minutes, it is easy to overcome antibiotic pressure. So antibiotics exist as a valuable source for all. Antibiotic therapy can cure an infection. Overuse leads to resistance. Resistance leads to the value of the resource. Resource becomes depleted. No novel antibiotics presently. Antibiotics no longer a widespread occurrence of the carbapenem resistance is alarming. Resistance to polymyxin and tetracycline is a commonplace now. Loss of improvement in ICU survival rates is alarming. Calls for universal screening of the MDR gram-negative bacilli. Where did the antibiotic development go? Antibiotic drug development is costly and time consuming. For a new molecular entities which are antibiotics, it takes about years for the newer discoveries. There is a decline in the number of new antimicrobial agents. Only two new antibiotics have been approved since the IDSA 2009 pipeline status reports. Since 2009, only 16 antibiotics were in development. Reasons to optimize the usage are antibiotic usage suboptimal. Total outpatient usage in the US and European countries is as follows. Prospective observation study in a 650-bedded hospital was observed, and it was found that 30% of the days of therapy were deemed unnecessary. Administration of inappropriate antimicrobial treatment was statistically more common on hospital-acquired community hospital HCAP patients, that is, healthcare-associated pneumonia. Then, through a number of studies, it was observed that 50% of the antimicrobials were inappropriate, then 30% did not meet the criteria for the treatment, and 30% prescribed were inappropriate. What are the factors that is leading to inappropriate use? Internally, it is a lack of knowledge. Double coverage is better for killing. Then expanding the spectrum is considered better. Lack of knowledge about dosing, about the spectrum of activity. Lack of knowledge about the allergies. lack of knowledge about when to give and stop the antibiotics, and prophylaxis outside of the surgical theater. External causes include lack of time to educate the patients, lack of microbiological data, fear of malpractice, misperception that antibiotics have only benefit, no harm, and pharmaceutical detail. Doctor, can you answer this? Education is awareness. That's the thing required. How many patients last year grew with VRE, that is vancomycin resistant enterococci? The resistance is alarming. To optimize the antibiotic use also includes antibiotic overuse and ensuring resistance impacts health and economy. Annually, about 30% of the hospital admits are due to infections. 2 million people develop hospital-acquired infection. Yet, 50% of the antibiotic orders are unnecessary. CDC recently provided estimates that nearly 50% of antibiotics prescribed are unnecessary. So, improving the uses of antibiotics. Studies have demonstrated that inappropriate initial therapy is an important independent determinant of mortality. Drug resistance hinders the selection of effective empirical therapy. Lower, lower, Lowering the rate of antimicrobial resistant infections from 13 to 10% was estimated to save nearly $1 million per year in the medical. Toxin deficient infection is problematic when three factors are aligned: coexisting morbidity, disturbing microbiota, and exposure to vegetative cells or spores of C. difficile. Antibiotic exposure is the single most risk factor for development of Clostridium difficile. Total incidence of 7,100 cases per year, including long-term acute hospitals, were observed, and it was observed that nearly 9% of the Clostridium difficile infections ended in death, and more severe cases of the CDI infection were attributed to and inappropriate drug utilizations. A SHP definition of an adverse event is unexpected, unintended, undesired, or excessive response to a drug. And serious adverse event is defined as patient outcome is death, life threatening, hospitalization, prolonged, and disability, congenital and others. Antibiotic resistance can be considered, hence, rightly as an. The government and insurers do not want to pay for the consequences of the antibiotic. Pressure also rate, foreign body, left body, post-operative physiologic and metabolic derangement, and many others are considered as to penalize the hospitals. Similarly, antimicrobial resistance has been under consideration for. The new requirements focus on the development and implementation of evidence-based practices, periodic risk assessment, measurement and monitoring of rates of infection, and education of staff and patients. Professional societies should endorse for the sharing an article here from IDSA and Society for Healthcare Application in America, which mentions about the guidelines for developing institutional program to enhance antimicrobial. There are reasons to optimize the antimicrobial use and the role of antimicrobial stewardship. Preventing infections, preventing the spread of resistance was the first step and first most core action, followed by tracking and improving antimicrobial prescribing and developing new drugs and diagnostics. The public media have made consumers into smart shoppers who seek safe health. The main target of the program is to improve patient safety to active interventions and healthcare provider education. Many reasons to control antibiotic use include antibiotic overuse accelerated bacterial resistance. The result of the feature is that about Clostridium difficile infection is alarming. There has been published guidelines and success stories employing stewardship strategies, which exist in great numbers, which provide valuable. Thank you.